important, or the patient has reached full skeletal maturity, and actually the patient has to be fully aware of the possibility of regrowth of the lesion, regrowth of the lesion, particularly as most of the cases are not often resected. In cases of polystotic fibrous dysplasia or macunal pride syndrome, where the disease is extensive, actually the surgery is often impossible. And as we said before, the histology does not predict the biological behavior. So what are the other lesions that could mimic fibrous dysplasia that we had to resort to biopsy in such cases? We have Budget's, for example, where in the early stages it manifests as fibrous dysplasia, yet in the advanced stages shows cotton wool appearance with extensive sclerosis. We have osteosarcoma. It shows mixed radio-opaque and radiolucency, or sometimes radio-opaque densities, and it has to, but the only differential point is the cortical destruction and local thinning. Other important lesion that should be differentiated from fibrous dysplasia is cherubism, which is actually familial fibrous dysplasia, and it also autosomal dominant, involved mainly in the mandible and premolar areas, and is not actually included under the classification of fibro-osseous lesions. And such lesions could be manifested radiologically as multiple unilateral radiolucency with multiple impacted or supernumerary teeth. So when you decide to biopsy, when exactly we can say we can resort to biopsy lesion? Only if the site is amenable. Whereas if the lesion is quiescent or asymptomatic, or it involves the cranial base, we do not resort to biopsy in such case. And there is a belief that some of the biopsy the biopsy called induced growth of the lesion, but we have to emphasize that the biopsy does not induce growth of lesion, but unfortunately bleeding can present since the lesion is vascular. Therefore, the surgeon should be ready to deal with that situation. The second lesion is ossifying fibroma, which are neoplasms in the true sense, exhibiting progressive proliferative capabilities with bony expansion and, importantly, well-defined margins radiologically. That has to be differentiated from fibrous dysplasia, the first lesion we mentioned, that has ill-defined margins, blend imperceptibly into adjacent bony structure without expansion or destruction, plus other features that could be differentiated from fibrous dysplasia, such as ossifying fibroma are mostly monostotic, whereas fibrous dysplasia is polystotic, and ossifying fibroma is unilocular lesion, and it shows eggshell thin calcifications, and sometimes if there is described as punched out appearance, and sometimes if there is local thinning or thickening of the lesion, it will be known as moth-eaten appearance, whereas fibrous dysplasia shows the ground glass densities. Regarding the specific subtype, there are 4 types of ossifying fibroma, but it has to be emphasized that these are only on histological wise, but academic basis or radiological wise, they are referred all as ossifying fibroma. So what are these subtypes? These are semimatoid variant, trabecular variant, gigantiform cementoma, and finally cemento-ossifying fibroma. We're going to discuss the 2 important types of them according to the site and location. The first one is trabecular juvenile ossifying fibroma, which occurs mostly in the maxilla and the mandible, and origin in exthagnathic locations are extremely rare. So it's clinically manifested as progressive and sometimes rapid expansion of the affected area, and crucial point, it is a painless swelling. The second type, the semitoid juvenile ossifying fibroma, occurs mostly in the exthagnathic craniofacial bones, with mostly like periorbital, frontal bones, ethmoidal bones, and is manifested as bone expansion that can involve if it involves the orbital bones or the nasal bones. If it involves the orbital bones, it will result in blindness, ptosis, disturbance in ocular motility, or babilla edema, and in case if it involves the nasal bones, it will result in nasal obstruction. What are the other lesions that mimic ossifying fibroma besides fibrous dysplasia that should be differentiated from? Is focal cemento-osseous dysplasia. And how can we differentiate that? Actually, by few little radiological points. The first one, irregular mixed radiolucent opaque pattern, whereas ossifying fibroma shows pure radiolucency, and the focal cemento-osseous shows well-defined borders, and ossifying fibroma can occupy a larger size and cause jaw expansion clinically. It shows close association with tooth apices or with previous extraction sites, whereas ossifying fibroma actually shows no relationship. And most importantly, focal cemento-osseous dysplasia is a benign non-neoplastic process, whereas ossifying fibroma is a true neoplasm. So now, for the third type, osteoma, which is the most bony content, we can say that this is a benign osteogenic tumor characterized by compact or cancellous bone proliferation that occurs mainly in the craniofacial bones. They could be divided into three types according to the site. If it arises from the periosteum, it will be known as peripheral osteoma, which occurs most commonly in the paranasal sinuses, or other locations could be encountered, such as orbital wall, temporal bone, pterygoid process, as well as external ear canal. If it arises from the endosteum, it is mostly known as central osteoma, and if it arises in the soft tissue, it will be known as extraskeletal osteoma. So now, what is the etiology for most of the osteomas and the first time for peripheral osteoma, they believe to be unknown, and some authors say it's reactive rather than neoplasm associated with trauma, and in cases of mandibular osteoma, some authors say muscle traction plays a role here. So the clinical picture actually is asymptomatic, which is most of the cases, and they discovered incidentally on routine and clinical radiographic examination. It could be a painless swelling, or if it's larger size, it could cause facial asymmetry and functional impairment, but it has to be noted that larger size than 60 millimeter is very rare indeed. It's mostly unilateral and well-circumscribed mass, ranging the maximum size from 10 to 40 millimeter in diameter. What are the other lesions that mimic peripheral osteoma? The first important one is exostosis, which is, how can you differentiate that? It's mostly multiple and located in areas of gingival mucosa and frequently associated with local trauma or in regions that received cutaneous graft. The second lesion is peripheral osteomyelitis, and the third lesion is peripheral ossifying fibroma, which shows well-defined, thin and radiolucent lines separated from the surrounding bone. And we have to emphasize that there are two types of ossifying fibroma: peripheral ossifying fibroma as well as central ossifying fibroma. Peripheral believed to be biogenic granuloma associated with calcification and fibrosis, and it's not. Some authors say it's not doesn't belong to the ossifying fibromas at all, and they say in Britain, for example, they call it fibrous epilis, whereas central ossifying fibroma arises from the interosseous, arises mainly in the periodontal ligaments in the mandible around the premolar and molar areas. Regarding the second type, the central osteoma, there are lots of lesions that mimic central osteoma, but we can say that the crucial point that differentiates central osteoma from all such lesions is painful swelling. We keep talking about central osteoma and peripheral osteoma. So what are the differences? How can we tell between both of them? The first central osteoma is the well-delineated sclerotic lesions, whereas peripheral one is radiopaque lesions, and central osteoma shows the smooth borders with no surface irregularities or satellite lesions, whereas peripheral osteoma has expansive borders, and central osteoma, the adjacent cortex, is not involved or weakened, and some authors described it as one half of billiard ball attached to the underlying bone, and peripheral osteoma is sessile or pedunculated, and actually most of the cases are peripheral osteoma. So now, an important point regarding osteoma, where the dentists play an important role in diagnosis of chronic polyposis, is the Gardner syndrome. That patients mostly with multiple osteomas should be evaluated for Gardner syndrome, which is autosomal dominant disease and characterized by multiple GIT polyps, predominantly adenomas, which may progress to malignancy in 100% of cases, unfortunately. The second, multiple osteomas, earlier stage, skin and soft tissue tumors, and most importantly, multiple impacted or supernumerary teeth, where the dentists here play an important role in the diagnosis. So now the aim of my work actually to assess the role of multi-detector computed tomography in assessment of fibro-osseous lesions of craniofacial complex. Regarding the methodology and the inclusion-exclusion criteria, we have to mention that the study was conducted in 25 patients using MDCD in detection of the lesion and assessment of the extension. It was a combination of prospective, about 16 cases, and retrospective, 9 cases. Their age ranged from 15 to 64 years old, with a mean age of 38 years old. It has to be noted that 13 out of 25 cases were pathologically proven to be fibro-osseous lesions, and 9 of them were surgically operated. Only patients with expansile bony lesions were included, whereas those who have been proven to be soft tissue or metastatic were excluded. An important point, it has to be highlighted that 12 out of 25 cases were pre- and post-contrast studies using up-tray at the contrast. Each patient is subjected to 5 important points: to full history taking, full clinical examination, especially to the head and neck, plain X-ray, MDCT, and finally 3D reconstructive images. And one important note that has to be repeated several times, that the final diagnosis was made by consensus of imaging, clinical findings, and pathological features. So now we come to our results and display of our cases. The majority of the cases actually were female, constitute the major portion, lie in the age group 40 to less than 50 years, with almost equal distribution among the other age range. The female constitute about 60%, followed by male 40%. And according to the final diagnosis, fibrous dysplasia constitute the major portion, about 12 patients, followed by 9 patients osteoma and 3 patients ossifying fibroma, and only 1 patient brown tumor. According to site of predilection, the maxilla and the mandible with the predominant size for fibrous dysplasia, followed by equal distribution for almost all other sides. And in the case of osteoma, the frontoesmoidal sinus was included, and other sides such as high palatal external auditory canal, and the same applies for ossifying fibroma. There are only 3 cases, mostly were shown in the ethmoidal sinus, and 1 of them presented by biroptosis. So now we come to display our 8 cases, which actually most of them are interesting. The first case is a 19-year-old female patient complained of left-sided baneless streak swelling, pathologically proven to be fibrous dysplasia. We can see an axial section shows the diffuse expansile, mixed lytic and sclerotic osseous lesion showing growing ground glass densities involving mainly the sphenoid bones as well as the frontoparietal bones on both sides, but mostly in the left side, with distortion of the orbital bony framework as well as the nasal fold and the skull base of the anterior and middle cranial fossa. And the most characteristic point, or the important point, is such a case with the encasement of a still patent skull base foramina. And here we can see patent foramen ovale, foramen biforamen spinosum in the left side. And here an axial section of the maxilla, the same case, shows a baccolingual displacement involving the alveolar margin with implication of the incisive foramina and extension to the right side with displacement of the overlying teeth. And here an axial section of the mandible showing baccolingual expansion with displacement of the overlying teeth. And a coronal section shows a free foramen spinosum in the right side. And here shows preserved superior orbital fissure, yet it's still encased. And here in the axial section shows a narrowed optic canal, though the patient does not complain of any visual changes. And here is encasement of a still patent optic canal. And we can see in the coronal section the encasement of a still patent skull base foramina, mainly foramen rotundum, followed by Vidian canal. And sagittal section shows involvement of the frontoparietal bones as well as the maxilla, and the mandible and clival involvement has been noted, and distortion of the nasal fold could be demonstrated here. And finally, the 3D VR shows the distortion of the orbital bony framework, the nasal fold, the maxilla, the mandible with displacement of the overlying teeth by the previously described lesion. So now we come to the second lesion, which is 55 years old female patient with non-fibrous dysplasia, complained of headache and nasal discharge. And I have to say the first lesion actually underwent about 19 surgery because the lesion started since she was 12 years old. But because she didn't wait until the skeletal has reached full skeletal maturity, the lesion regrows one more time. So this is an important note I have to mention the first case. The second case, we can say an axial section shows an expansile mainly sclerotic osseous lesion causing baccolingual expansion involving the alveolar margin, but with no implication of the incisive foramina, neither displacement of the overlying teeth. And here, the sagittal section shows involvement of the pterygoid plates, and the coronal section shows the involvement of the pterygoid plates. The third case is a 22-year-old female patient complained of headache, paranasal discharge, and forehead swelling. We can see a diffuse expansile, mixed lytic, and sclerotic osseous lesion involving mainly the right nasal cavity, deviating the nasal septum to the left side. And an axial section shows complete obliteration of the ethmoidal air cells. And we can see axial section shows complete obliteration of the frontal bone as well as the ethmoidal air cells with distortion of the orbital bony framework and optic canal implication as well. Axial section the same as before, but shows the extension of the lesion. And here the coronal section shows the lesion occupies mainly the inferior turbinate involving the lateral wall of the nasal cavity and shows medial extension through the medial wall of the orbit with indenting the medial rectus muscle, and here involvement of the parietal bones as well. And sagittal section shows involvement of the frontoesmoidal bones as well as clival involvement could be noted. And here the 3D VR shows the briefly described lesions with orbital and nasal disfigurement. The false case is a 15-year-old male patient complained of proptosis and headache, pathologically proven to be ossifying fibroma. We can see a sizable, expanding soft fibro-osseous lesions centered upon the right nasal cavity, displaying faint ossifying densities and hypodense cantilucent areas. It indented the medial wall of the orbit, indenting the medial rectus muscle with extracoronal extension and consequent proptosis of the corresponding eye. And here the coronal section shows extension of the lesion, where superiorly it violates the ethmoidal roof with consequent extension to the anterior cranial fossa, and medially, we can see involve a complete obliteration of the nasal cavity with remodeling of its lateral wall and consequent projection to the maxillary sinus, which shows retained secretion. And here laterally occupies most of the cavity of the left nasal cavity with consequent retained secretions. And we can see the sagittal section shows the anterior extension of the lesion through the frontal sinus, which shows retained secretion, and posterior extension through the sphenoid sinus with limited extension through the posterior carina. And finally, the 3D VR shows the orbital nasal disfigurement. The fifth case actually is a 15-year-old male patient with pathologically proven ossifying fibroma, complained of headache, nasal discharge, and obstruction, but the patient showed such a lesion in axial section, which shows a soft fibro-osseous lesions epicentered upon the ethmoidal air cells, shows dense sclerotic osseous lesion with cantilucent areas, as medially indenting the medial wall of the orbit, yet no definite global compromise has been noted. And here the coronal section demonstrating the indentation of the medial rectus muscle, mainly involving the lamina papyracea and indenting the medial rectus muscle, and infralaterally shows extension through the maxillary antrum with consequent retained secretions in the maxillary sinus, and intact ethmoidal roof has been noted. And we can see here the infralateral extension with complete obliteration of the osteomeatal complex. And the sagittal section shows the extension of the lesion anteriorly through the frontal sinus and posteriorly through the maxillary sinus. And the sixth case is a 45-year-old female patient with no renal failure. She developed hypoparathyroidism, multiple facial brown tumors, pathologically proven to be brown tumor. We can see in axial section a sizable expanding soft fibro-osseous lesions epicentered mainly upon the left nasal cavity, laterally causing obstruction, laterally occupying most of the cavity of the maxillary antrum with consequent extension into the masticator space, and the maxillary antrum shows retained secretion. The maxillary antrum in the right side shows extension, deviation, the nasal thinned out nasal septum to the right side. And here the axial section shows the extension of the lesion, where anteriorly it extends through anterior nasal aperture and posterior through the pterygopalatine fossa, reaching the base of pterygoid plates. And here the coronal section shows complete obliteration of the ethmoidal air cells as well as the maxillary antrum. And the coronal section shows the superior extension of the lesion, where it involved the inferior orbital wall, which is very rarefied, indenting the inferior rectus muscle as well as the medial rectus muscle with consequent proptosis. And finally, the sagittal section shows the inferior extension of the lesion, where it reaches the hard palate, which is thinned out, as well as the alveolar process of the maxilla. The seventh case is a 33-year-old female patient complained of left-sided mandibular swelling. We can see from the axial section a dense sclerotic osseous lesion arising exophatically from the left angle of the mandible, expanding the caudal part of masseter muscle, yet no intramuscular extension, and associated with a sclerosis of the marrow angle of the mandible. And we can see here in the coronal section. And in sagittal section, the sclerosis of the marrow angle is well demonstrated in the sagittal section. And finally, the 3D VR showed the osseous structure arising exophatically from the left angle of the mandible. The last case actually is a 64-year-old male patient complained of sinusitis. We can see a dense sclerotic osseous lesions arising from protruding from the frontal sinus in the axial section. And the coronal section shows encroachment upon the frontal outflow tract. And sagittal section shows extension within the frontal sinus with consequent retained secretions. And finally, the 3D VR showed the osteostructure protruding from the frontal sinus. So now we come to conclude 3 important points regarding fibro-osseous lesions, that they make up a diverse collection of disorders that include neoplastic and non-neoplastic, hereditary and non-hereditary conditions, and they share similar histopathological features with other lesions. Therefore, a definitive diagnosis requires a correlation of histologic features with clinical, radiographic, and intraoperative findings. And now we come to the importance of MDCT. There are 5 important points. Actually, including reformations, better delineate craniofacial complex anatomy than do single detector raw CT images, and it becomes possible to depict the complete path of complex structures. And it has to be noted, it's become valuable confirmed to be valuable in the diagnosis and in guiding the surgical interventions by allowing preoperative delineation of craniofacial complex of a complex anatomy, where the proximity of various components is best appreciated when the area is viewed in axial and coronal sections, and different reconstructive methods using submillimetric thickness. And should be noted that coronal oblique MBR should be considered as an alternative to the standard orthogonal CT examination, but it represents a valid integration to provide additional information structures that have complex outline. And finally, multi-detector computer tomography is proved to be a powerful diagnostic and illustrative tool that will narrow the gap between radiologists and surgeons. Thank you.
Thank you. Any questions?
Okay.
Microphone.
Good morning, doctor. A very, very good presentation.
Thank you.
I'm an oral pathologist.
You're a pathologist?
Yes.
Okay, hello.
I have been studying the PET scans, positron emission tomography.
Sorry, I can't.
PET scan.
PET scan, yes.
I just wanted to know what is the usefulness
Of PET
in
scan.
diagnosis of PET versus the MDCT scan that you do.
Okay, actually the radiological regime that has been used for the fibro-osseous lesions was PET scan, then followed by plain film X-ray for the increased areas of increased radioactivity. Then we come here to play the role of MDCT, assessment of the extension of the lesions. So the first thing is PET scan, but in this study we're emphasizing the role of multi-detector in assessment of the extension so that it can narrow the gap, as I say, between the surgeons and radiologists. So the first thing is PET scan followed, Okay. Sorry? No, PET scan costs a lot more. And most of the patients actually resort to the MDCT first. Because most of them are asymptomatic. Unless the artificial asymmetry or deformity of this, that's why they have to go to do an MCT. But most of I've mentioned in my lecture, in this presentation, that most of them complain of paranasal discharge, headache, something like that. Unless if something very visible, they just go. And unfortunately, most of the cases were thought to be diagnosed as sinusitis. And then when I undergone the MDCT, we found this soft fibro-osseous lesions. Okay, my pleasure.